Hello, good morning. I'm very sorry I can't speak Italian. I hope you understand English. Yes?
A little bit.
So I will try and speak as clearly as possible. I agree with the colleague behind this gentleman who's speaking now. He is so right in what he's saying about the way healthcare providers, clinicians, nurses behave in hospitals these days. Their behaviors are very, very inappropriate. But we have to consider also the very difficult environments in which healthcare providers work. So I will talk about our work in patient safety, we call it, and quality improvement. The gentleman who spoke here talked about quality improvement indicators, and he says transparency, we can't do it because of transparency. This is wrong. This is not right. There's quality indicators, and hospitals do quality indicators, whether you are in Italy, in Belgium, in London, in Vietnam, even in Africa, and this has nothing to do with transparency. It's a process that hospitals have. Transparency is a different issue. It's an important issue, but it's nothing to do with quality indicators. I do not agree with his statement before. So let's just focus then on unsafe care, the harm that we as healthcare professionals do to our patients, and the ethical aspects around this. By the way, the presentations, what I'm saying in English is translated into Italian in your folders. So basically I would like to start to say that ethics is everywhere in healthcare. And in the past 2 decades, we have focused ethical issues mainly on professional integrity, how doctors, how nurses, how pharmacists, how healthcare workers behave. And we have focused it on research that is done on medicines, such as the embryo research or DNA research. This is full of ethical issues. And we have also focused it on data gathering and analysis. When we do research on human subjects, we have very, very strong and serious ethical committees that have to approve of the research that we're doing. We have also focused the ethical aspects on the delivery of health services. And this is what I will be talking about today. I'm only going to focus this presentation on the delivery of safe care and the ethical aspects that surround this area. And this is the focus on safety and quality aspects of healthcare delivery. So throughout this presentation, we're going to use words like, sorry, I'm blocking your view, words like medical error, patient harm, substandard clinical care, unsafe care, negligence, and violations. The last two are very, very strong ethical aspects. So where do we see healthcare ethics in our environments? We see it in many areas of operation. And what ethics does, it is a framework of basic fundamental principles of our human nature that guide and help the behaviors and the practices of doctors and nurses and pharmacists and all healthcare providers. They guide their behaviors and their practices. So the ethics principles that we have are very, very important. And where do we see the interaction of these ethics principles? We see it between health professionals and patients. We heard today by my colleague Daniele and by the previous speaker how important it is to take care of patients and to have the right behavior towards patients and to respect patients' rights. The other behavior which is ethical is between peers, between doctors themselves, between doctors and nurses. I come from the UK, and we have in the UK some really bad behavior between doctors and nurses. Doctors, surgeons, excuse me endocrinologists, orthopedics, speak very badly to the nurses. And this is what we, as WHO, fight. This is an unacceptable behavior. But at the same time, we see the same thing from the nurses' point of view. The nurses group together in little teams and they fight the doctors. So we have to stop these behaviors. So this is the second. This is behaviors, unethical behaviors that exist in hospitals and clinics between peers. Peers is people of the same level and employees. Then we have leadership. Leadership is the CEO of the hospital, the politician, the guys who dictate policies, and they have to be transparent. This is where transparency is very important, and they have to be fair to all their staff. Again, there's ethical issues here. Finally, it's the organizational culture. This is the culture that prevails a hospital, a clinic, a nursing home, a maternity hospital, a primary health care. There is cultures in organization, and they're cultures of safety, they're cultures of justice, they do exist, and they're cultures of blame. I will talk about the blame culture, but I want to explain here what a blame culture is if Daniele makes a mistake, forgets a gauze inside the patient when he operates, we as the peers are going to say, Daniele has done very bad. Daniele should be punished. This is the blame culture. The blame culture does not work. In all hospitals in the world, the majority of hospitals, not all, we see a blame culture. Blame culture is very bad. It does not contribute to safety and to progress. So let me continue. Sorry, I haven't done something important here. Yes, I have to do it like that. I beg your pardon. That's better. Now, yes. Now, I'm going to talk about the 4 principles. There's 4 main principles in healthcare ethics, in medical ethics. I'm not going to go into details, but they're autonomy. Autonomy is to do with telling a patient what his illness is, what the diagnosis is, and the potential processes and clinical care that we can provide as doctors, and let the patient decide. Let the patient have the autonomy to decide whether he wants to do chemotherapy if he has cancer, or whether he wants to do traditional and complementary medicine, go the Asian way. So it's up to the patient to decide, and we have to respect the patient's autonomy. The second is justice. This is in our world, in the world where we have global health care, we see that there's huge injustice in African countries or poor countries where there's a term access to health care. The rich people have access to health care. The poor people do not have access to health care. So this is a very wide discrepancy where, there's an injustice in health care. But even in our European countries, or US, or Canada, or Japan, the rich countries, or Australia, we have injustice in healthcare where some top interventions are provided to the well-off patients, the patients that have a good insurance, but not the same interventions are provided to the less patients with less money. So justice also applies in, our cultures. The third important ethical aspect, ethical principle, is beneficence, and this is to do with healthcare providers knowing their skills, their training extremely well to be able to do good to the patient, always do good. And this links to the non-maleficence, which is do not harm a patient. And this is the old Hippocratic oath where, doctors had to swear, I will not harm a patient. These are the 4 basic principles which is in the literature, but in addition there's more, like truth-telling. You always tell truth to the patient. There is dignity. You treat your colleagues and the patient with dignity, even if they are a bum that drinks alcohol and sleeps in the street. And confidentiality, of course, this is a prevailing issue in ethics, confidentiality of patient information. Now, there are certain behaviors that are linked to these 4 ethical principles. The first one, which is to do with beneficence, is professionalism. We need to be professionals. We need to know our trade. We need to know our skills. We need to know how to deliver healthcare. Responsibility and competency. We constantly need to be competent in what we're doing, be trained. There's new techniques in surgery. Daniele becomes competent in these new techniques. He was telling me about some of these techniques back in Geneva. So he keeps up his competency level by training. Openness and flexibility. We don't have cultural barriers. We are open to what the patient says, and we are flexible to the patient's needs. This is very important because the patient's needs can be physical, can be mental, can be behavioral, can be cognitive, can be emotional. So we have to be very open and flexible about the patient's needs. We have, of course, to respect human dignity, patients' rights. We've talked about this. We have to be honest and trustworthy and fair, and also show some characteristics of what we hear from religions, such as altruism, compassion, and empathy. These are words that, without the religious context, these are words that do not exist really in healthcare. People don't understand what empathy is, although there is a lot of doctors and nurses that show empathy. So these are words that need to be introduced in the medical training. The last thing is important. Don't treat others as we would, or rather treat others as we would like to be treated ourselves. Don't do to other people what we don't like being done to ourselves. So although we have these very basic principles and these very basic behaviors that we expect all our healthcare professionals to do, doctors, nurses, physiotherapists, midwives, pharmacists, the realities where these people work are very different, and we have to look at these realities because they're the bad system element that changes the behaviors of healthcare professionals. The realities of our everyday lives in hospitals is that they are very busy. Hospitals are very busy, very noisy, very pressurized, very chaotic environments. There's very little time. We see patients after patient after patient. We have very little time. We are busy because the next patient is waiting. There's another patient that is having a heart attack in another ward. It's a very chaotic and difficult environment. And in these environments, the brains do not work properly. They have lapses in their concentration, and this is what creates errors. In hospitals, healthcare generally, we have very bureaucratic and unnecessary processes. We are repeating processes. We are not streamlining our work there. We have a lot of complex technologies. We have radiology equipment. Last year in Chicago, in one of the very big hospitals, very top hospitals, they received some new radiology equipment, and the doctors were not, or the radiologists were not trained how to use them. So what did they do is they irradiated the patients with 200 times the dose that they should be receiving. So they did more harm to the patients than necessary, basically because they didn't know how to operate the complex technologies, the complex radiology equipment. So this is another problem. Our problems in hospitals are that there's too many specializations. We have endocrinologists, oncologists, what have you, so many professions that they all need to work as teams, and this is very difficult. We have too many patients, too many distractions. Healthcare professionals are tired, sleep deprived, they're sleepy because they work for long hours, they're anxious, they're fearful, they're stressed, they're depressed, they are unsupported, they lack specific training. Now, when you work in these environments and under such circumstances, things go wrong for sure, errors are made for sure. Healthcare providers, healthcare professionals do not do their work properly, and as a result, patients are seriously injured and die. Some of them die. So we have here a challenge, which is a challenge in all hospitals in the world, whether it's European hospitals or African hospitals or Asian hospitals. Everywhere in the world it's the same. There is unsafe care everywhere, and I will show you some data in a minute. Whether we're talking about the large hospitals or the small primary centers where you have a one-to-one basis between the patient and the doctor, there's errors everywhere. If you look at any given minute, now that we speak, hundreds of millions of patients around the world are seriously injured or are killed. And I will show you the data. Errors, why do errors happen? They happen because healthcare is a very complex environment. It's one of the most complex environments in the world, and because of behaviors. We heard the word behavior a lot today. We have to modify and improve behaviors of healthcare staff. Now, many adverse events, medical errors, we call them adverse events, an event which is not wanted, an adverse event. A 2000 study showed that 2/3 of adverse events are preventable, and yet we're not doing anything to prevent them. So let me show you this very interesting little shape here. Forget the first box. See the scalpel here. We have the sharp end of the scalpel and the blunt end of the scalpel. And this is an image that is used quite a lot. Now, the sharp end of the scalpel is where there is an active error, where a doctor or a nurse does harm to a patient. And this is called an active error. The blunt end, which is all from here down to here, it's the health system. And it's all the hidden failures in the system that contribute to this active error taking place. This is bad protocols in place, this is bad processes in hospitals, this is no control systems, as the previous speaker said, no regulatory system, this is legal systems, this is a lot of things that can go wrong in the health system within a hospital or a clinic or what have you, that contribute to active errors taking place. Now, I've used this scalpel because this is an example that is, if you look at the literature, they always talk about the sharp end and the blunt end. So this is an illustration to show exactly how the problem is progressing through the bottom to the top. Now, let's take a scenario here. Let's take an example. And it's in the paper that is given in your folder. We have a clinician that prescribes an opioid painkiller to a patient. The nurse administers it. He prescribes a high dose of the painkiller. The nurse administers the high dose of painkiller. The patient then becomes unresponsive. He has shallow breathing. He has a faint heart rate. And this high dose of painkiller, of opioid painkiller, caused patient harm. Now, in our discussions here today, who is ethically responsible for harming the patient? Is it the doctor who prescribed the high dose of the opioid? Is it the nurse who administers? Now, a patient who receives vincristine normally knows that vincristine is injected through IV, not intrathecally. So if there is communication with the patient can say, hey, stop. Vincristine does not go in the spine, it goes in the vein. So this is one very important reason why we should engage verbally and communicate with patients to avoid errors. So, I just want to repeat what I said before. Remember the scalpel? We have active errors at the top, which are done by healthcare professionals, the doctors, the nurses, and we have a whole series of hidden failures in the system that are causing the active errors to take place. Now, there is a very important sociologist, anthropologist. It's in the paper. His name is James Reason. He did his work about 30 years ago. And he came up with a model, the Swiss cheese model. And this is a good model to illustrate how errors happen. Now, if you take the slice of the Swiss cheese, it's the cheese with the holes inside. I'm sure you have it here in Italy too.
Oh, it's okay.
Yes. So imagine each hole is a protective barrier to a care that is being given to a patient. So let's say the first barrier is procedures, is we have good clinical procedures in case, we have good guidelines, we have good protocols. The second one is safe use of equipment. It's very important because the equipment is complicated. We can harm patients by not knowing how to use equipment. A third layer can be a patient information. For example, is the patient allergic? What is his blood type? This patient information needs to be there, and it's also a protective barrier. Clinical decisions. Who takes clinical decision? If it's junior staff, new staff, we know they make mistakes. This is standard. All junior staff, when they go into a hospital, they make errors. And this is why it's a must that they are supervised by senior staff. Is the junior staff who's taken a clinical decision supervised? So if he's not, then he makes an error. So you can see here, if an error in the first slice of the cheese, if an error is made in the procedure, if a clinical procedure is not followed properly, the second layer, the error does not go through the holes because the second layer acts as protection. However, if we go to the next slide here, you will see the same shape as before, but you will see that if the system is very weak and if it has hidden failures, there's no barriers here, for example, with the equipment, there's no proper patient information, the allergy is not mentioned, or the blood type is not mentioned in the patient record, and a junior staff who doesn't know his or her work properly is taking a clinical decision. If all this is allowed to happen, then the error goes through and the patient is harmed. I think this is a very good illustration to show how an error takes place. Now, I told you about data. I want to show you some data because the situation is serious, and I want to prove it. Here, there is a slide. It's not translated into Italian, but you will see 3 columns. Here's the numbers of encounters, of things happening, of incidents for each death. We're talking about deaths here, and this is lives lost per year. You will see here the very safe industries in the world, the regulated industries, and the dangerous industries. The ultra-safe industries are transport, aviation, trains, nuclear power, the safest industries in the world. The most dangerous industry in the world is healthcare. It is healthcare, the most dangerous industry in the world, at the same level as the guys that do mountain climbing or jumping from the skies, you know, with a parachute. It's the same level of danger. You cannot compare the danger in healthcare with aviation. It's 2 different things altogether. So, for the past 20 years, it's not just bad news, it's good news as well. For the past 20 years, the world has progressed a lot in the areas of safety of healthcare and quality, as we talked before. We have defined what the science of safety and quality is. We know the areas, we know what the priorities are. We have developed a lot of solutions. I don't have time to talk about the solutions now, but I can tell you there's surgical checklists that surgeons should do before they operate. There is hand hygiene and infection procedures, infection prevention and control procedures that should be done in order to prevent the spread of nosocomial infections. There's medication safety protocols in order to prevent errors in administering drugs, medications to patients. And I have to say, in hospitals, 70% of the errors are because of medication safety or unsafe medication. So we have done a lot of things. We have done campaigns. I know there was a hand hygiene campaign in Italy, and I know that that was done 10 years ago or 8 years ago, and I know in the hospitals there's clinicians, either in wards or in their pockets, they have the alcohol hand rub to do hand hygiene. That is all there. So the system has done its work. Do the healthcare professionals do it? No. The data shows that 60% of doctors and nurses do not do hand hygiene. And it's more doctors than nurses. So even with the solutions there, we have the behaviors that don't go parallel. So let's continue quickly. This is some examples that I'm showing you from the US. Healthcare-associated infection, you have, this is nosocomial infections. With nosocomial infections in the US, for 2014, this is CDC data, it's 1 million a year, and this costs USA billions of dollars. A 2013 meta-analysis about medical errors showed that in the US, there is 400,000 deaths per year. 400,000 patients are killed because of the delivery of care and not because of their illness or condition or disease. Adverse events in hospitals harms between 4 to 8 million people a year. So this is just hospital data. It's easy to measure hospital data. It's difficult to go beyond. This does not include data from the primary care or nursing homes or maternity homes or clinics. It's just the big hospitals. So you can imagine it's like the tip of a massive iceberg. We only know the data of hospitals and we don't know the data in the rest of healthcare. So these deaths are much more than what I'm saying. Now, this is a very interesting article that was published in the British Medical Journal this year, and it says that in the US, can you see the purple here? This is medical error. 1/3 of hospital patients' deaths in the USA are because of medical error. 1/3 patients are killed because of medical error. You can compare it with cancer, with heart diseases. You can see this is a big chunk. Medical error is very serious, and it's full of ethical issues, this area. So we really need to focus on this. Let's go to the next slide. I'm going to give you some specific examples, again from the US. I'm saying the US because they have data. They're the guys that generate data. Not other countries generate such data. Hand hygiene in hospitals fails 60% of the times. Communication across transitions in healthcare. What this is about is when a nurse hands over, because she changes the shift, she goes home, there is the night nurse that comes, and she tells this transition in healthcare, she gives the patient information to her colleague, another nurse. Or the nurse communicates with the doctor. This is transitions in care. Communications across these transitions in care fails 40% of the times or more. That means incorrect patient information is given between healthcare professionals. In the US, we have operating room fires 600 times every year. I mean, this is ridiculous, operating room fires. We have 50 unsafe surgeries per week in the USA. 50 unsafe surgeries per week. This is too much. And also in developed countries, we hear UK, France, I'm sure Italy, you hear a lot of reports about injuries of deaths of patients in the media. And this is also an indication that things are not right. Now, we're not only talking about numbers, we're talking about real people. You have your patients as nurses. I don't know how many doctors here, you have your patients. We're not talking about 60% of this does not work and 40% of that does not work. We're talking about real people that we have damaged and we have killed. And these are some people here and their families that we know personally, the World Health Organization, and they have linked with the World Health Organization, and some of them, the ones that are alive, are champions pushing for this cause. Do I have a time
It's okay.
problem?
No, it's okay. It's okay.
I just want to show you this nice chap here. He's dead now. He was a sky jumper. He was going up in planes, and then he put the parachute on, and then he jumped down. That was his sport, okay? So in one of his falls, he crushes his elbows, his head, his shoulder, his head, so he has to go to the hospital. He goes into the hospital, he stays there for a while, he gets okay, he recovers, he gets out of hospitals. He has caught nosocomial infection in the hospital, and he dies a few months later because of a nosocomial infection. So you can see how clinical care from one point of view helps a patient, but at the same time, you have all these problems in hospitals that can cause their deaths. This chap here, Nelson Bailey, he had a routine operation, and they forgot a gauze of this size inside him, and that was huge, and they didn't know what the problem is until they operated again and they removed the gauze. So we're talking about real people here. This slide is to say that unsafe care is very, very expensive. So it is much cheaper to invest in quality and safety, because then you don't waste. Can you see the second bullet here? This is recent data. I don't want to show you the old data. In the UK, medical errors cost the country up to £2.5 billion a year. 2.5 billion pounds. This is a lot of money. I don't know what is the thing between pounds and euros. Whatever. Nevertheless, it's in the billions of euros. It's quite a lot. So, what are the ethical aspects of unsafe care? We've talked about beneficence, we've talked about non-maleficence, and we've talked about patient's autonomy. The first one is, the beneficence is the moral basis against errors of omission, is if we don't do something right to patient. A very simple example is if we go and see a patient, if we go and touch a wound and we don't do hand hygiene. Therefore, when we touch with our hands a wound or close to a wound, we can give nosocomial infections because of our hands. So this is, we're not doing something right. Non-maleficence is doing errors of commission, which is incorrect dosage of drugs, for example, if we do not do something right. And autonomy is going back to the story where a patient has the right to decide about himself, his own treatment, or what have you. Now, accountability, again, it's an ethical issue, and it's a very important issue because we all expect healthcare professionals to be accountable. And this is an ethical and has an ethical and legal basis. And while these requirements vary from profession to profession, for example, nurses, pharmacists, doctors, the accountability aims to give confidence to the community and the people that when you go into a hospital, when you go to a clinic, the people there have the ability and the training and the skills to do good to the patient. This is accountability. Accountability is a professional obligation, and it's an ethical issue. Let's go back to our scenario with the clinician that has prescribed a higher dose of an opioid killer. So again, who is accountable in this mistake that happened? Is it the clinician who is overprescribed it? Is it the nurse who has given the opioid, administered it? Is it leadership who has omitted to bring more healthcare staff in order to help existing doctors so they don't work for 36 hours? So these are all legal issues, and the only way we can come to the basis of things and see who is accountable is by doing a systems thinking. So analyzing an error. If we analyze this error, the traditional attitude, as I said in hospital, is to blame, is to say, you are at fault, or you Costas are at fault for doing such and such harm to the patient. But the blame approach, this is called the blame approach, does not work. Healthcare and hospitals, healthcare system as a whole, has for too long, for decades and decades, been blaming doctors and nurses for mistakes. This is absolutely not right, because remember the scalpel, you remember the active error and all the system's failures that contribute to this error taking place. So blaming approach does not work. it creates the second victim. The first victim is the patient. The second victim is the nurse, for example, who's administered the high dose. In the US, we have nurses that have committed suicide because they have administered and killed a pediatric patient or a patient. They've overprescribed, they've given a higher dose of a drug, and the patient dies, and they feel so bad, they commit suicide. Or the rest of their life is ruined, not because of, the professional consequences, but because of their consciousness. They can't live with that fact. So the doctor and the nurse becomes the second victim, and a blame approach does not work. So one would have to use a systems approach. This is something that we are saying in the literature. You will see in the literature that a blame approach does not work, but a systems approach works. In this particular case with the clinician, we can say that the clinician was not supported enough by the system in order not to make the mistake of giving a higher dose of the opioid painkiller. Now, what is a just culture? I'm finishing. A just culture is always uses a system approach to understand medical error before blaming any particular doctor or nurse for doing an error. The second thing is the fact that you're saying you use a system approach. That doesn't mean that healthcare professionals do not have a professional accountability on what they're doing. They are responsible and accountable for the work that they do. At the same time, we have a systems accountability too, where a system holds itself accountable. In other words, it has the right processes, the right mechanisms in place, the right safety policies, as we talked before, so that it becomes accountable, has trained its staff to be accountable, and also the staff know by themselves how to be accountable and hold themselves ethically responsible. I want to talk the last two slides about violations. Violation is if healthcare professionals do something wrong. They do not deliver clinical care as they should. And we have three types of violations, and you're healthcare professionals here, so you will understand them. The first one is it's called a routine operation. Let me just say, it's routine, necessary, and optimizing. The routine operation is if inadvertently, when you don't want, you make an error. That's because you haven't been taught, you haven't been trained that you need to use a checklist before you open up a patient. So if you don't know, you're making an error because you haven't checked the allergies, you haven't checked the blood type, you haven't checked whatever, and an error is made. But if you don't know, this is a routine violation. You do a violation not by choice. The other two, the necessary and the optimizing, is a violation you do because you have a choice. The necessary is when you skip a protocol, if you don't do all the steps of a protocol because you don't have time, because you have too many patients to see, because you're too pressed, because you're too anxious, so you skip protocols. Typical example is when a midwife does not take the progress of a pregnant woman who's just about to give birth. So she doesn't measure because she's got another 10 women to see. So she knows she's skipping a protocol, but she does not have time. Now, I have to focus here on normalization of deviance, and this is very important. I think it's called organizzazione della devianza. Devianza? Devianza, thank you. And the next slide is going to be about that. The optimizing violation is the worst, and it's calculated, and it's done by healthcare providers for their personal benefit. They know they're violating, and they're violating for the benefit. And this is when a big shot, a senior doctor who has to see his private patients to get money from his private patients, ignores his public patients, leave his public patients with a junior doctor that does not know how to do things properly, and goes instead to get money from the private patient. This is called an optimizing violations, and it's very, very close to negligence. Now, very quickly through this slide, this is all linking with the normalization of deviance. In healthcare, we have learned about safety and ethics and quality from the big disasters that have happened in the world. And they're really good lessons for us. And I'm going to mention 3 that you all know: Columbia disaster, the shuttle, the Challenger shuttle disaster, the Chernobyl nuclear accident, and now the Fukushima. I haven't put it here because the data is not coming out yet. Now, what we saw from all these accidents is that small violations, what we talked about before, and it was type routine and necessary violations that happened consistently, whether it was building the Columbia shuttle or the Challenger shuttle or operating the Chernobyl nuclear plant. There were violations done by all staff, little violations. And these small violations became normal, because if you see your colleague, for example, not doing hand hygiene, you say, oh, why should I do hand hygiene? And then the other nurse sees, oh, why should I do hand hygiene if he hasn't done, if she hasn't done? So you don't do a procedure. So this is called normalization of deviance. If you become insensitive to a safety protocol or a quality protocol or a clinical protocol, and you skip a step. Everybody's doing the same. Everybody, sorry, let me go to the next slide, because here, this is what we talk about healthcare. In a clinical environment, we see that whole departments, nurses in whole departments, they skip important steps in clinical care, and they think it's normal. That's because everybody's doing it. This is called normalization of deviance, and it's like an illness. It's an illness, a culture illness, that can spread across healthcare and across hospitals, and we have to watch this. So, are deviant behaviors, normalization of deviance, an ethical concern? Yes, they're very, very much an ethical concern, and we have to focus on these things. And the problem about ethical normalization of deviance is that if you don't do hand hygiene, or if you don't do the checklist, I'm just giving 2 examples, the surgical checklist, you think it's normal because no one else is doing, and because this violation of behavior becomes diffused to the department, to the whole, so there's a diffusion of your responsibility, and therefore it becomes normal. So what are the take-home messages from this presentation? Is that almost all areas in healthcare have ethical issues. And we only talked in this presentation about ethical issues that are specific on the delivery of unsafe clinical practices. So these ethical dilemmas that we see are observed between the doctor and the patient, the doctors themselves, or doctor and nurse, and between the healthcare staff and the leaders. The subject of patient safety is really very interlinked with ethical aspects, the 4 principles that we talked about before. We showed you in this slide an illustration of how a medical error happens, the Swiss cheese model. I think it's a very good model to remember. We've talked about the blame cultures and the system cultures, why we shouldn't be blaming healthcare providers for mistakes they make, but at the same time, they themselves must be accountable for their actions. And finally, what is accountability? What is a violation? The type of violations, and the normalization of deviance, which is a very, very important issue. So I'm going to close this presentation. Thank you very much.